Okay, no epilepsy, a call to action to reduce stigma. I want to acknowledge the generous support of the Ontario Trillium Foundation, who have developed many of the teaching units that we use here in Ontario, and the Ontario Brain Institute and Eplink for providing funding for us to evaluate them, and for inviting us here today to talk about this important topic. In the next 25 minutes to 30 minutes, I'm going to build on what Melissa started with and talk about the International Bureau for Epilepsy, where I have learned about cultural stigma. I'll talk about the hidden distress model because I think it's really important to the work we do here in Ontario, and some interventions that reduce stigma, including individual and family education, workplace and school support, the political advocacy we do, public awareness, and call to action. Can you hear me? Perfect. Terrific. I have the privilege of volunteering with the International Bureau for Epilepsy, otherwise known as the IBE. It's a global organization that has 137 chapters around the world. Our mission is to improve the social condition and quality of life of people with epilepsy and those who care for them. We have a vision of the world where understanding and care replace ignorance and fear. Our members are patient organizations. We don't really call them that, but our members are groups like the Canadian Epilepsy Alliance, the Epilepsy Foundation, but national epilepsy organizations whose mandate is to provide care for people with epilepsy. In my role with the IBE, we have funding. So we have, one of our programs is Promising Strategies. So we've been able to give 83 different lower and middle income countries project funding up to $5,000 US to develop programs to reduce stigma. So programs like information and support in Indonesia, traveling caravans in Romania, programs in Zambia, programs in Mongolia, and programs in Ethiopia. The IBE has also been formally recognized as an official partner in relations with the World Health Organization. And probably one of the, there's been a lot of highlights in my epilepsy career over 20 years, but one of them has been speaking in this room. So we spent in 2014, China asked the World Health Organization if we could put epilepsy on the agenda. And it's no easy task to get epilepsy on the agenda of the World Health Organization. It's no easy task to get any time on the agenda because they're dealing with such major international problems. But we did lobby governments from around the world, and we had our day in May 2015 where we were able to speak. And I remember sitting in this room, and I was on the speakers list, and they'd given me all this instruction. They said they have a green light, a yellow light, a red light. When the green light goes on, you start. When the yellow light goes on, that's your 15-second warning, and the red will just cut you off. And I remember how exhilarating that experience was. And we've been back about 4 times. I haven't spoken again, but I'm going to tell you all my colleagues from around the world that have spoken have all thought it was just tremendous. But what did we do in 2015? We managed something I think that's really important. We managed to get a resolution for epilepsy. It's called WHA 68.20, and it acknowledges that there is a global burden of epilepsy, and there is a need for coordinated action at the country level to address the health implications. This was a huge deal. And beside me, I have my friend Jacob Mugambage. Jacob is from Zimbabwe. And he joined me at the World Health Organization to talk about epilepsy from the perspective of a stakeholder. So he shares a story that I think is vitally important. His sister, when she started having seizures, they lived in a rural village. And it was about 300 kilometers from the only place that you could get medical care. And like Melissa had mentioned, she had gone through all the traditional healing approach, and it hadn't stopped her seizures. She had lost her marriage, and both of her children had been taken away, and she had been banished from the village. When she found out through her brother, who ended up going to university, that there was epilepsy care, because they didn't know that this was a medical condition, they saved for a year as a family to get her a bus to get to see a doctor. So I'm trying to rationalize all that, and I'm thinking, why would that be? But what we have to realize is that some of these countries are really poor. So in Zambia, where Jacob's from, per capita, they spend $25 US a year in healthcare, okay? I looked at what we spend in Canada. Well, it's $6,800 a person, or $252 billion a year in Canada on healthcare. And I don't know, I'm sitting here as an epilepsy advocate thinking, and we still haven't really got it right, right? So, but this is all the money that we're spending to do this, okay? So we have looked at the IBE for different models, and she's here in the room, what we've decided is that the best way to really change the world is to get youth to talk about their epilepsy, and we're going to hear that later on today. But these were 2020s, 20 North American youth who came together to talk about finding solutions to reduce stigma in epilepsy. We have started this around the world. We've got kids from every continent where we can find them talking about epilepsy. So the other thing we do at the IBE is we try to share information that's really important. And one of the things that I like to share is a journal article by Paula Fernandes from Brazil. And her comment is, stop saying epileptic. So words we use can influence our perceptions and have consequences in terms of stigma. And here's an example. Do you think that persons with epilepsy are rejected by society? Or do you think epileptics are rejected by society? She went to teachers, healthcare providers, and regular Joe public. 41% think that persons with epilepsy are rejected, but 87% think epileptics are. So remember, the words you use are critically important. And we learned that again from Southeast Asia. So epilepsy is associated in many cultures with with insanity and animals, such as goats and pigs. And in fact, the character for epilepsy in Southeast Asia is dirty pig. Okay? So we have to be mindful of this, and our colleagues in those regions have tried to change the name, and they've been very successful. So I'm proud to say in Malaysia, Hong Kong, and South Korea, they've taken it from this name to something that talks about brain conditions and being a brain disease. All right, let's talk about institutional stigma and interpersonal stigma and all the stigmas that Melissa introduced to us. So it disappoints us, and something we're working on internationally, that there are many regions of the world and countries of the world that have lifelong driving bans. The whole English Caribbean. India, China, Southeast Asian. So I'm talking about if you have a child with seizures that outgrows their seizures, but has had one seizure in their life, they'll have a lifelong driving ban. So what we know about this is that this absolutely restricts access, and these are punitive institutional laws that are not correct. So marriage. Marriage is also an area that we see population health studies towards that show stigma, in particular interpersonal stigma, which Melissa talked about. So in all regions of the world, your marital prospects and outcomes are diminished in epilepsy, all regions of the world. Regions with a strong cultural perception of the disease that rely on the non-scientific explanation, so those that think it's contagious, a form of insanity, so we're talking now all of Sub-Saharan Africa and Asia, have poor attitudes. So how poor? Well, they range from Ecuador, which is not in that region, to 22% saying I wouldn't let my loved one, my child, marry someone with epilepsy. Moving across, Kuwait 55, Russia 57, Greece 66, but the biggie there is Korea at 94%. So you mentioned something interesting too. Does it come to Canada when an immigrant or a new Canadian comes from these countries? Absolutely. I had a professor from the University of Western Ontario who was from Korea. He insisted that we meet at the university to talk about his daughter, because he said if anybody saw him walking into my door, she'd never be married. So it wasn't long ago in North America that you were forbidden to marry. So in 17 US states until 1956, the last state to repeal it was in 1980, in the UK 1970. The Hindu Marriage Act only made it legal to marry someone with epilepsy in 1976. And in 1956 in the US, 18 states sterilized people with epilepsy, which is what they were obviously doing at that awful place that they took people to. But nowhere in the world is it more punishing than in Sub-Saharan Africa. So when we say Sub-Saharan Africa, it's the bottom of Africa, not the Muslim countries at the top. In Ethiopia, 83%, and in Nigeria, 88% said, no, I would not allow a loved one to marry someone with epilepsy. And these are recent statistics. I think what's more important is that if you think of how these villages work, and you did a great job of showing that, if your role in the community is to provide the food, fetch the water, prepare the meal, and you're deemed not eligible to do that, then you're banished from the community in many cases. So women with epilepsy are actually living in poverty. And Gretchen Burbach did a great study where the sexual assaults rates for women with epilepsy in Zambia were 20% versus 3% in other conditions. You don't like to say all of these sensationalized things, but it is, I don't want us to think that this is okay, so I have to say it. We had a Kenyan doctor that did a door-to-door census and found children latched to animal cages in the backyard and not living in the house with the rest of the family. And when asked, they said, oh, that's the one that does this kind of thing. So they know this. They've done their census and they know the stigma exists. I'm not allowed to use the same eating utensils as other people in the family. But the biggest thing is it puts women who can't own property and are dependent on their husbands in these countries, especially in rural communities, at extreme risk. You talked about Stigmata. This is a blog done by a U.S. healthcare provider. This woman fell in a fire in Africa, and nobody pulled her out. This woman, though, is going to change things. And so there's always, for every side of it, there's always the positive side. She lost her marriage when she had seizures. She said her husband just didn't want to be with her because she was contagious. And she is making it her business to educate people about the proper way to get treatment and the proper way to get health. So what we know is people with less knowledge about epilepsy or without personal contact with someone with epilepsy have poor attitudes. And the magnitude of these negative attitudes is even greater where there's misperceptions about epilepsy, where the culture thinks it's a form of insanity, it's untreatable, it's contagious, it's hereditary, or it's a form of learning disability. So, where do we get our information about epilepsy? Well, hopefully not from Grey's Anatomy and House. So Andrew Moeller is from Dalhousie. He's a medical student. He got to spend a whole summer watching TV, lucky him, and where he saw there were 65 seizures, 81% were convulsive. We know that convulsive is not the most common seizure type, but it's certainly the most dramatic and the one that works best in the movies. And 43% of the seizure response was wrong. Dalhousie obviously had a lot of people wanting to do this kind of work because McNeil did it as well. Watched 10,600 plus tweets in a 48-hour period, followed them for a week, and 41% were derogatory. So our negative stereotypes promote concealment, and concealment heightens internalized stigma, okay? And so the other one I was going to put up was just too classic, but it was epileptic man kills neighbor with fish knife. When you read the story, they had a dispute over something that had nothing to do with his epilepsy, and they both lived in a marginalized part of England, and they fought each other. But it had nothing to do with that, but everybody watching that would think it had very much to do with the fact that he was epileptic. Okay. So, I want to talk about non-disclosure, and I want to talk about it based on the hidden distress model of epilepsy. So in the late 1980s, Scambler, who was a sociologist from the UK, came up with this term, and it's still as relevant today as it was in the late 1980s. And basically, he said, when someone is diagnosed with a condition like epilepsy, which is stigmatized, they immediately have to decide what's next. So they consolidate all the images they have in their mind about what epilepsy means and looks like. So they think of the House series, they think of a psychotic guy, they think of that convulsion on the floor and it might have looked grotesque. They just think of all of these things. But they most of all have to decide, do I tell or not tell? Who do I tell? How do I tell? When do I tell? Do I have to tell my employer or do I not have to tell my employer? Do I tell my neighbors? Do I tell my friends? And all of these questions become distressful for the person with epilepsy. He talked about the parent of the person with epilepsy becoming a stigma coach. You shouldn't tell people. And encouraging their children to not tell teachers or showing by example that you keep all of it in and you don't tell anyone else. But what he talks about that's the most important is internalized stigma, when we don't talk about it, is way more disruptive than when we do talk about it. And that's the biggest problem with it. And what he said is that all the research that's been done in the world, and I know Jacoby out of the UK has done this, showed that 90% of persons with epilepsy in several studies have showed they've experienced internalized stigma. Only 30% had experienced enacted stigma. So when it is safe to disclose, it's the healthiest strategy. So it might not be safe to disclose in Sub-Saharan Africa right now because we haven't put the tools in place to let the community understand how to treat that person. But hopefully in London, Ontario, when I go back to my work, it is safe to disclose because the laws protect people and it's the way to reduce stigma. Scambler also said something I think is vitally important. He said, we can have stigma reduction and education campaigns, but they're not enough. You must work with the individual at a psychological personality level. And I know, Jeff, you've always talked about that just giving information is not enough. You have to make people feel comfortable, and Rosie, you've talked about it as well. You have to make people feel comfortable talking about it. You need to address the social, emotional, and psychological consequences of this disease. And you need to discuss the bidirectionality of depression. You need to discuss the loss of control and you need to discuss the fear and the worry. And until you do that, you will not reduce stigma. So you can stop all the seizures you want, but the person with epilepsy will feel internalized stigma until you help them cope with all those other things. So how do we decrease stigma? Social support lowers stigma. Melissa talked about peer support does. There's evidence counseling does. Reducing fear and worry and providing information and support. And disclosure reduces stigma. Significant internal conflict is greatest for people who hide their epilepsy because they feel shame and anxiety because they're keeping this secret. General investments in medical care don't lead to improvements in epilepsy-related stigma. To reduce stigma, we need to direct funds toward epilepsy information and stigma reduction programs. And I use the example of the mosquito net. You can hand out thousands of mosquito nets in Africa, but if they're ripped, if they don't cover the body, if they're put on top of a bed that doesn't have a mattress and has slats in the bottom, you're still going to get bitten by the bug. Read a book just recently called A Mind Unraveled by Kirk Eichenwald. Now, this is Kirk's memoir. So Kirk is my age. When I was at Queen's in 1980, Kirk was being kicked out of university in the States because of his seizures. And I started to think as I read that book, how far has it come? Because I was helping a girl, a London, Ontario resident who was at Carleton, they were trying to kick out of her residence because she was having seizures. And she was just too disruptive for the other classmates in the corridor. And this is exactly what they said about Kirk. He has written 5 books, writes for the New York Times, is an editor at Newsweek. And he tells his story with a riveting passion that only a stakeholder can, because he talks about how every time he wanted to disclose, he had to weigh, will I lose my job or not? Will I be considered the reporter who only talks about disability? Will people treat me seriously? Will they allow me to participate? But he had this line, and I just really thought it was powerful. He talked about the terrifying loss of control that accompanies convulsions, leads to a sense of powerlessness, with the neurologist taking the role of the only possible savior. Great words, terrifying, powerless, savior. Other epilepsy patients I've spoken with experience the same paralyzing, another great word, desperate dependence on the neurologist, a feeling that can override common sense or the courage to question decisions. Started thinking about that, in particular in the way that one gets a doctor for epilepsy in Ontario. So typically, after you're diagnosed after you have a seizure, you go to your family doctor, and your family doctor will, go through their Rolodex in their brain, and if you've got a regional or a district epilepsy center, you're probably going to get a great referral. But if not, you'll get whatever person they know that will take you, and they'll likely pick the one that has the shortest wait list and say, you know what, I'm going to refer you to Dr. X, and Dr. X will see you in probably 3, 6, 9, 12 months, depending on where you live. So I was thinking about this dependence on the doctor and how our healthcare system perpetuates stigma. In this way, you wait for that 6 months or that 8 months to get that vitally important appointment. They talk to you about what happened, requisition some tests, try to localize where the seizures begin in the brain and give you a medicine and say, we'll see you in 6 or 9 or 12 months again. Nobody discusses the hidden distress that the person with epilepsy feels, which is really at the core of stigma. And you mentioned the core of wellness, because if you don't reduce that stigma, you don't reduce the seizures. And this is so vitally important. If you don't address the depression, the seizure medications don't work to the same extent. So it's a really big cycle that we have to start thinking differently. And so we have developed a program called Clinic to Community, which is to coordinate care in epilepsy. And thankfully, the Ontario Brain Institute and the Epilepsy program has given us funds to try to put this program in place and to evaluate it. What we know is that at diagnosis, if somebody is given the time of an epilepsy educator, in our case it's in the community, just spend an hour and a half together to talk about epilepsy, that group will tell you they feel less anxious. Well, that's one of the ways we reduce stigma. They feel like they can better manage, and more importantly, they feel like they can reduce injury, or as importantly. So basically, the way this program works is we provide information, we provide knowledge and support, and that leads to empowerment. The ability to make shared decisions, not, what did I say earlier on? Not feeling hostage to your neurologist, but decisions that you're making as an individual. Ability to care for yourself, which is the chronic disease management model. Ability to disclose, to self-advocate at school and in the workplace. Your ability to advocate for changes in policy and funding. All of this information that you give to a stakeholder will change the way they approach their whole condition. So we're saying in Ontario that there's just 3 easy steps. If every single doctor that diagnosed somebody with epilepsy was mandated to refer them as a clinic to community patient, then every person in the province would have epilepsy information and education at diagnosis. And people will say to me, well, that's not possible. But I'll say to you, it's what we do with diabetes. The minute you're diagnosed with diabetes in Ontario, you're given a referral from what was your CCAC, who knows what it'll be in the future, but you're given up your diabetes education. You're met with somebody who teaches you to count carbs. You're met with somebody who teaches you to understand your condition. And the thinking behind it is that in self-management programs, people do better. So you're not a burden to the system. You're not unemployed. You're not falling out of school. You're actually doing better. So it improves health from day one, and it does it by providing information and reducing stress. Okay, so right now in Ontario, I put this up, we're asking for our government to make those changes. We're asking for them to fund programs like this. But stigma gets in the way all the time with epilepsy, in that if we ask for 100 people to come to an appointment and talk about stigma, or if we ask for 100 people to write a letter, maybe 2 will, right? And that's part of being stigmatized. It's that powerlessness. It's that feeling that you can't make a change, you can't make a difference. And that's what's happening all over the world. And it's really, really problematic. So I'll go back just briefly to the World Health Organization. After we passed that legislation, the rubber hit the road. We had to go back to all those countries. 194 unanimously said, yeah, epilepsy is a priority. Now, 4 years later, not one of them has funded anything. And they're coming to us and saying, I've never met a person in some of these countries who's ever told me that epilepsy was important to them. That's not a problem for my country. I hear the autism parents, they're out there. I hear the other groups, but I've never heard anybody come to me to say epilepsy is a big deal. So why would I change things? Why would I base funding and funding in it? So that's part of stigma. When you make people feel powerless by not putting the system in place for them, then the system continues to take advantage. Okay, survey says, what am I doing for time? I gotta go fast. Do you think that persons with epilepsy have more difficulties in getting employment? Or do you think epileptics do? Well, 62% said 93% basically said epileptics have more problem. Unemployment is a problem for people with epilepsy in every country in the world. Every single country in the world. And it depends, it can go from outright discrimination in places like Southeast Asia where you're not entitled to have a job at all, to kind of covert discrimination in our communities, where you might be passed over for promotions or given different shifts. So that's part of the big problem. When they've done population studies in the States and said, you know, what would be a reason you wouldn't hire somebody with epilepsy? You get kind of lame things like, it doesn't fit with my public image, or I wouldn't want to have to burden my other staff by helping that person if they have a seizure. So we've got a long way to go on employment, and you're in the best hands here with Epilepsy Toronto, because they've got the best programs in the province and probably country. So, but we're not doing well. 50% of Canadians with epilepsy are unemployed. 35% say they want to have a job, 15% say they're disabled. So we have to look at the roots of a comment like that. So when somebody says in my office, I did not apply for the job, and I say, oh my God, because they will never hire me because I have epilepsy. It's very different than somebody coming in and saying, yesterday I had a seizure at work and they fired me. One is enacted stigma. If you had a seizure at work and they fired you, we can do lots with that, because we'll go right at them from a legal perspective. But if you didn't apply for the job, the support that we have to give is very different. And that goes back to that psychological support to build the person up, to make them feel like they are as worthy as someone else to have that job. And I often find it very interesting that, and I don't have epilepsy. So when I had migraines, though, I never worried about telling my employer that I might have a migraine at the office. So it's a very different thing. Now, I didn't have to be kept safe as well. So when I think about that hidden distress model, the other fear that people with epilepsy has, if I don't tell somebody and I have a seizure at work, will I be saved? Will I lose my job? Will I be fired after the seizure? So there's so much in this condition that we need to address. And we need to address it from a systemic perspective, where we're getting people at the time of diagnosis to learn what they need to manage this condition well. Do you think that persons with epilepsy have more difficulties in school, or do you think epileptics do? Well, now you're on to the survey, I know that. Well, 70% thought the epileptics had a lot more problem with school. So again, if I've reinforced anything today, is don't call yourself an epileptic. I hear it all the time at work. I hear I'm an epileptic. You're not an epileptic. You're a person that happens to have epilepsy, okay? And I hear it a lot. And I actually heard grand mal too, and I'm just going to say that I didn't put it in my sides, but grand is big, mal is sick. Do you want to have the big sick? Do you want to? Because keep saying grand mal, and we got to get doctors to stop saying grand mal too. You have generalized whole brain, or both hemisphere, tonic, stiffening, clonic shaking. That's what you have. And those words were changed so that we could reduce stigma in epilepsy as well. Okay. Oh dear, I got to go fast. I was invited to China to speak about schools programs, and in China, children with epilepsy don't go to school, so that was my first shock when I stood up. They basically are not allowed to go to school. It's terrible. A systemic review of knowledge and attitudes towards epilepsy among school teachers in 27 countries. I don't think a single one was in Canada, but there were 4 American studies, found deficits in teacher knowledge and negative attitudes in every study. Teachers don't receive formal training in epilepsy, and several studies indicated that they lack adequate knowledge about seizures. So what we do here in Ontario is we use a program called Thinking About Epilepsy that we developed in about 2005. We go into every grade 5 classroom in our service area, and I know it's being used in many areas across Ontario. It's an evidence-based program, which means that we did research on it, and we proved that the program, through a randomized control trial, improves knowledge and improves attitudes. And this program in our service area alone has seen 35,000 grade 5 students. We teach an empathic response to having a seizure. And so every child in the classroom understands how they can be a helper and a friend to somebody that has epilepsy. I am so proud that the program is going all over the world, and these are kids in Kenya that are using the Thinking About Epilepsy program. But we have a very multicultural Ontario, and I often think if we have people from all over the world in our Ontario classrooms, does the little girl from Syria and the little boy from Myanmar and the child in the back from Ethiopia and the girl from China, do they know epilepsy is a brain condition, or do they know about epilepsy from the perspective of where they grew up? Because we know that the family is your number one teacher. And what's important to note there is in schools, we can develop curriculum, and we're going to continue to develop curriculum, but the number one teacher of epilepsy to teachers is a parent. All of the research says that the number one way they get their information is a parent. So we have a responsibility, if we're going to decrease stigma, to get appropriate, evidence-based information into the hands of parents of children with epilepsy. So this is my colleague Rochelle, and this is my reminder to thank EPLink for the funding for our school-based program right now that we're evaluating. And why are we evaluating? Well, a student who is absent 15 days per school year will have missed the equivalent of 1 year instruction by the end of grade 12. So you need to think about this because we have longitudinal studies in epilepsy that show children with epilepsy are failing in schools. They're graduating and they're not graduating into jobs. Is it absenteeism? Is it stigma? Is it the brain condition itself? We don't know, but we need to be changing that kind of data. One of the ways we can change it is there's lots of missed health days in any chronic condition. You have doctor's appointments that are during the day. You have medications that you try or don't work, or you have post-seizure events and you don't go to school. What we can change, though, is overprotectiveness of school staff and parents who unnecessarily withdraw children because they don't understand that that child can contribute and be a member of that class at the same level as everyone else. That's where we can make changes, and that's where stigma is the most obvious part of school for kids with epilepsy. So, a couple more slides. Kudos to Epilepsy Ontario for changing the legislation. We now have policy memorandum number 161, which means that Ontario teachers have to have a plan of action for children with epilepsy. It's given us a new life in schools for being able to educate about epilepsy so that they understand how the condition impacts the child. Purple Door Workplace Campaign. So Purple Day, I think, is actually a really good stigma reduction campaign because it is a campaign that asks persons with epilepsy, stakeholders, to tell people, I have epilepsy and it affects my family. That's the number one way you'll reduce stigma. Because earlier on we talked about people who stigmatize don't know anybody with stigma. You'll find your neighbor who finds out that you're impacted by epilepsy will be far kinder. And Purple Day gave people an opportunity to disclose, and disclosing reduces internalized stigma. So we have this, I don't know if this is everywhere, but on our website we're doing doors, so doors in offices, doors in schools, where they're doing purple doors. All right. So, second last slide. Just want to review the impact of epilepsy worldwide. I don't know if I told you, but there's 50 million people who have epilepsy worldwide. 80% live in lower and middle income countries, but only 25% get treatment for their epilepsy. It's awful. I don't know how we're allowing this to happen. I keep thinking of my kids, raising money for wells in Africa and raising money to do global citizens in Midway. We need to have a call to action, a global epilepsy campaign where we're raising money to change the lives of people around the world. This is awful. 10 million people in Africa have epilepsy. Only 25% will ever get treatment. And now we know that 70% of those drugs could stop the seizures in many of those cases and could give that person some quality of life or hopefully even full quality of life. That people with epilepsy are 3 to 6 times at greater risk of premature death. And the side there, the stigma and discrimination is a huge issue that needs to be dealt with in the family, in the home, in the community. We also look at the causes of the treatment gap, and those are, sorry, my eyes are so bad, but if you look at the bottom one, it's lack of political will. And that's never going to change if people with epilepsy don't come out and say this matters, or this bothers me, or this is not okay. So, who knew that you'd be here and I'd put a picture of you? I just thought it was a great picture. How do you decrease stigma? Ambassadors. You decrease stigma by empowering people to tell their story. And you decrease stigma by giving people the tools to say that epilepsy affects me, and I'm going to teach you a little bit more about it. So that's my segue into the 2 ambassadors, and I thank you very much for this opportunity to share stigma around the world.